Hi everybody. I think most of you on the call know me. For people that don't, I'm Jess, I'm the PCN pharmacist. I've been doing some bits for some of your practices, but not loads for others. So hopefully after this, maybe you'll think, oh, Jess can help with this or whatever. So yeah, I'll just share my screen because I have a PowerPoint. Can everybody see that? Right, so I just wanted to start off with sort of a horror story really that was shared by the coroners. It was a coroner's report about a lady called Faye. So her sort of story, this story started off with her having lower back pain after she lifted a fish tank. And she had an operation to sort out the back pain, but it didn't go particularly well. She was put on oxycodone 80 milligrams a day. This is obviously a very shortened version of the story. And people kept adding meds and increasing doses. She developed sleep apnea, and she died 4 years later of a respiratory arrest. So the inquest didn't conclude what had caused the respiratory arrest, but I think her medication list was, well, there were a lot of harms that the medication could have caused. So this was a medication list at the point when she died. So as you can see, oxycodone at a 200 milligram daily dose is massive, and massively above the morphine equivalent of 120 milligrams daily. Diazepam in there as well. Obviously, opioids and benzodiazepines can cause respiratory depression. And interestingly, they trialled gabapentin as well, but the only reason that it was removed was because it didn't suit her. So it would still have been in the mix if she'd not decided that she didn't want to take it. So how could these medicines have caused harm? In quite a few ways. So obviously diclofenac increases the risk of cardiovascular events, and there are normally better alternatives. As we've said, the dose of oxycodone was massively above the safe limits. Opioids and benzos can cause respiratory depression together, but also individually. So together the risk is a lot higher. Several of the drugs could prolong the QT interval. And just before she died, she was prescribed erythromycin, which can also prolong the QT interval, so that could have contributed. And there was also a question about erythromycin allergy as well. So I just wanted to go through QT interval prolonging drugs, just because I think it's quite frightening because they're so common. And maybe everybody's brain isn't there, you know, when you're prescribing, you don't necessarily think, oh, does it prolong the QT interval? So the more you add, obviously, the higher the risk. So I think on this page, these are really common drugs. So citalopram and amitriptyline I've seen together quite a few times. So yeah, that's that. And I think citalopram is a really good example as well, because citalopram, the maximum dose was decreased after an RTC looking at QT prolongation. So it was 60, but now it's 40. And for anybody over 65 or with hepatic impairment, the max dose is 20. So I was thinking maybe as an audit we could do, if anybody's over 65 and they're on a 40 milligram dose, it might be worth speaking to them, reducing the dose, or maybe swapping them to something a little bit more suitable. So the next bit is just about high risk drugs. So by a high risk drug, I mean drugs with a narrow therapeutic index, so like lithium, or the effect that the drug has on the body makes it a high risk drug. So for example, methotrexate knocks out the immune system, so we need to monitor it loads. Or the change in a person's condition affects the way that the body is able to deal with the drug. So for example, DOACs, and if the kidneys deteriorate while they're on a DOAC, then the body's not able to deal with a DOAC as well as it would have done in the first place. So Tara, can we have the first poll please about confidence and high risk drug prescribing?
Of course. Do you want to unshare your presentation and then I will ping up the poll? So poll number 1 should be pinging up onto your screens now. Okay, so sharing that looks as though we have got some positivity, that we've got some safe systems in place, which is good news, I hope.
Yeah, so that's really positive. So I won't make this presentation too long because everybody already knows what they're doing.
Should we try? I was going to say there was the. Oh no, hang on. I was going to say, do we want to think about people's own personal confidence as well? I've got another poll as well, so just stick this one up as well. So that's interesting. If we have a look at that, I'm just sharing those. So actually, whether we are reliant on our systems or being saved by our systems. So back to you, Jess.
Thank you. That's really interesting. Cool. So this is from the Pharmaceutical Journal, just the top 10 prescribing errors. I don't know when it's from, it might be a little bit outdated. So a lot of them, as you can see, involve high-risk drugs. Anticoagulants, opioids, NSAIDs, and drugs that need monitoring. We see all of these daily, so that's why I think this is really important. And also loading doses for example, amiodarone, for example, that's been continued on an initiation dose, a loading dose, rather than the maintenance dose. So I'll talk about amiodarone later as well, just briefly. So I think this is all about reducing risk, and monitoring obviously reduces the risk. You view the results of the monitoring against the recommendations for prescribing, and then go from there. And I think also keeping in mind that every time you do prescribe something, is the monitoring up to date? Is it something that needs monitoring? So yeah, that's what I've just said. So if the monitoring hasn't been done for something, you can always set some sort of safety net. So if you just put like an issue limit of 1, and then go back to it and just check that it's been done, just so that it can't, if you're doing a med review, for example, and you reauthorize for 12 months, then it's not done for another 12 months, you won't know. So I think that safety net's a really good idea. Oh, we've done that. So I'm going to talk about NOACs, a little bit, because I've done some work in one of the practices recently about DOACs. And I want to talk about them because they've got like a really individual monitoring schedule, and it's very specific. So I'm interested to know, how often do people think we need to check weight for DOAC monitoring?
Oh, and we can do a bit of fancy pants stuff here. If Jess unshares, this is where I'm getting slightly ahead of myself. Okay, so you should be able to see a Menti poll. So if you pick up your phone and you go to www.menti.com in your web browser and put in the code that's at the top of the screen there, 3987931, you should be able to write down in free text what you think the weight check requirements are. Got some people scribbling on the screen, if you haven't got your phone with you, I guess. So we've had some replies. So can you all see that? So we've got a couple of people saying annually or sooner if patients notice the change, so change in weight presumably. Depends on the creatinine clearance, mostly 6 monthly, but if impaired renal function, 3rd of November, presumably that's a typo, meaning 3 months, and then there's a couple more 3-month people. So back to you, Jess.
So, yeah, cool. So it depends on creatinine clearance. Yeah, it depends on creatinine clearance. So I'm going to skip ahead a few slides. Yeah, so the guideline on the medicines management website is that if the creatinine clearance is between 15 and 30, you monitor urea electrolytes and weight 3 monthly. If it's 30 to 60, it's 6 monthly. And if it's over 60, you monitor it annually. So basically, every time you check a U&E and a weight, you need to recalculate the creatinine clearance and check the dose is correct. At this point, you would also check for compliance and for signs of bruising or bleeding. So that's the advice from MMT. So, yeah, I think a few people were right. So I'm going to talk about the dosing of DOACs as well. So this is also based on creatinine clearance. And obviously to calculate the creatinine clearance, you'll need a U&E and a weight. That's why those things are so important, because you base your dose on that creatinine clearance. There is a bit of controversy about how to calculate a creatinine clearance. So some people use ideal body weight and some people use actual body weight. So the advice from MMT is to use actual body weight unless the BMI is over 30, in which case you would calculate a range. This is the advice because this is what was done in the clinical trials. So makes sense. So in obesity, I always use MD Calc, but there are other calculators that you can use to calculate a range, a creatinine clearance range. I've found that the range often crosses dosing boundaries. So in which case you would need to make a clinical decision. Are you going to err on the side of anticoagulation, or are you going to err on the side of caution in terms of bleeding? And HASBLED and CHADS-FAST are really useful tools to see sort of where people's risks are. So we've done monitoring. Other monitoring for DOACs. So a full blood count, a full blood count and an LFT annually, and check lipids as well is recommended by MMT. And also a blood pressure is a good idea because edoxaban is contraindicated in uncontrolled hypertension. I quite often see full blood counts and LFTs done at the same time as U&E, which is fine because it just makes the recall a little bit easier. So yeah, that's the norm, I think. So problems, particularly problems that I've seen, weight is often forgotten. I don't know if some people think it is only needed annually, or if it's not as important, but the weight is often not there. I think the most out-of-date weight that I've seen was from 2008 for a patient on rivaroxaban. So that's a little bit concerning. Because sometimes they do refuse to be weighed, but I've found that if you just have the conversation of why it's important, often you can get them on side. Some people refuse for bloods to be taken as well. It's a similar discussion, just this is important, we need to just check your kidneys are doing okay, and normally they're on side. Or sometimes you can't obtain a blood sample, for example, from people that are very, very elderly, in which case a clinical decision should really be made about whether we're going to continue the DOAC or whether we need to stop to warfarin or whether we still need to continue with any anticoagulation. So that's all I've got for DOACs. Does anybody want to ask anything? Please say no. Shall I keep going? Okay. So NSAIDs I've included for a few reasons. Obviously, the most common adverse effect is the GI effects, but these are quite well done. They're included in QOF, they're included in community pharmacy last year to make sure everybody was on a PPI that needed to be. I think what I really wanted to highlight was the renal effects and the cardiovascular effects as well. So I'm not going to go through why they're bad for your kidneys, but that's why. And the cardiovascular effects as well. So I was quite surprised to learn that all NSAIDs increase cardiovascular risk irrespective of baseline. So even if you're perfectly healthy and you just take a short course of ibuprofen, your cardiovascular risk has still increased, even if it's only slightly, but it's still increased. And loads of people are on them. So the advice is to review the need for the NSAID on a routine basis, which is really vague. And also nice clinical knowledge summaries say that we should monitor renal function at least annually. and monitor renal function 1 to 2 weeks after initiation or increasing a dose, which I don't think is done widely. Yeah, I think there are a few people that slip through this net. And also, if we're on long-term therapy or if there's existing hepatic impairment, we should be monitoring LFT as well. So that's it for NSAIDs and my little pet hates. So shared care drugs. Dr. George, over to you.
Bear with me as I mess around with me technology. Okay, so we are back on Menti in a second. I've shared it.
Can I just ask a quick question just before we go on?
Yeah,
Do you know with regards to when you said over creatinine clearance of 30 for the DOACs?
Yeah.
On the medicines management thing, it says obviously I know that when they've been doing their audit, they do it if it's over creatinine clearance of 30, they use the adjustment and obviously the sort of spread on creatinine clearance as ideal body weight. But the manufacturers suggest all the time, apart from dabigatran, to use actual weight. I know obviously you've already said it's sort of a contentious issue.
Yeah.
Do you what do you use, or do you just weigh it up with obviously the Chad's Vask and the Asbleds?
So I use actual body weight because I think is that what MMT recommend, actual body weight?
Well, they like you said earlier, I think up to 30 they use actual, but then above 30 they tend to use the spread.
Yeah.
But obviously I've always just used actual because all the courses I've ever been on with sort of anti-coag pharmacists have always just suggested up to 40 to use actual unless they're fluid loaded.
Okay. I wasn't aware of that, to be honest. The majority of stuff that I learned about DOAC monitoring was from the MMT pharmacists.
Okay.
So that's probably why. But that's really interesting and definitely something to look into.
Yeah, it was if you ever want to, it was Lee Lawrence. He was a pharmacist from Derby Way that ran some talks.
Okay.
And he always suggested essentially unless they're fluid loaded to stick to actual weight. But like you say, it depends on who you ask.
Yeah, exactly.
And I suppose as long as you stick to the same one all the time, it doesn't really matter.
Yeah, I mean, as I say, I've just been using a range, but it's definitely something for me to look into. And maybe if he's running some more courses, that might be an idea. Thanks very much.
Brilliant. So hopefully you can see up there, there's another Menti. So if you want to put in, if you know some drugs where there are some shared care guidelines, and then we'll see how much we know. What do we know? Because everybody had a go that wants to go, or anybody that's typing an enormous list. Great stuff. Right, back to Jess.
Yeah, so you were all right. They were all shared care drugs. So I just wanted to talk about this because I think there's often quite a little bit of confusion about what do we need to prescribe a shared care drug? What paperwork do we need? What do we need to know? So I'm going to touch on DMARDs, lithium, and amiodarone briefly, and ADHD only slightly as well. So the DMARDs, which you've all just mentioned, they're all amber. So they all require a shared care agreement apart from hydroxychloroquine, which is green after specialist initiation. So normally they'll prescribe a month's worth, and then just hand back to primary care. But there's no further, we don't need anything else from that. So for monitoring of DMARDs, there's a really good summary on the NICE clinical knowledge summaries, and they've got like individual summaries as well, not just as a bulk. So that's really useful. Hydroxychloroquine doesn't require routine bloods, but if the patient's on long-term therapy for over 5 years, annual eye checks are needed. And Dr. George sent me something the other day about actually the eye issues might be more prevalent than we initially thought, and at lower doses as well. So I think that's really important to make sure your patients are referred to secondary care if needed, just to have these annual eye checks. And then sulfasalazine monitoring apparently can be discontinued after 12 months if the patient is stable, but I mean, annual monitoring is probably still a good idea. So generally with DMARDs, monitor every 2 weeks until the dose is stable for 6 weeks, then every month for 3 months, and then at least every 12 weeks following that. Cyclosporin you would monitor monthly for 12 months, and then consider increasing up to 12 weeks if stable after that. So what do you monitor? UNE, FBC, LFT. With cyclosporin and tacrolimus, you need a BP and a glucose. And with leflunomide, you also need a BP and a weight check. So whistle-stop tour of DMARDs. So lithium I wanted to talk about, I put it in when we thought Priadel was being discontinued, but obviously that's on hold now, so it's a little bit less relevant than it was when I wrote the slides. But with lithium, we need a target serum concentration of 0.4 to 0.8. In bipolar, sometimes it's a little bit higher. And if there's been a previous relapse or the patient is rapid cycling, then the target can be up to 1. So any higher than 1, we start to see lithium toxicity, which actually can occur at 1 millimole, and it can actually occur lower, especially in the elderly patients. So when do we test the lithium serum concentration? 12 hours after the last dose, we test at the trough. And I learned this morning, because I went on the lithium training this morning, we test at the trough because if they're toxic in the trough, they're likely to be toxic the rest of the time. So that's a good time to test it. Brands are not interchangeable, as we're going to talk about with the Priadel swap. There is some lithium training from MMT. There's a couple of sessions left next week, and I think the practice managers have got the link to send out if you wanted to go on it. I went on it this morning, it was really good. So this is all about the swap, basically. So the serum concentration to be taken 12 hours after the dose, then to be taken again 7 days after swapping the brand. And we just need to highlight to the patient that the signs of toxicity, which are listed there. But this has been put on hold until April next year, so we don't know if it's going to go ahead. We don't know if Priadel is going to be discontinued then. And then amiodarone. I'm not going to go through all the monitoring requirements of amiodarone, but it's a good idea to be aware that it does require 6 monthly monitoring. I think this one slips through the net quite often as well. And it's a good idea to be mindful of the side effects, so that if somebody rings you up and says, I've got blue skin, and they're on amiodarone, you would know why. So that's that. And then the ADHD meds, I'm not really going to go into them. I just wanted to put them in because I'm going to talk about controlled drugs, and I thought it went quite nicely from shared care to controlled drugs. Because obviously methylphenidate and lisdexamfetamine are CD2. So a little summary about prescribing shared care drugs. Just ensure that the shared care agreement's in place, it's signed and it's in date. Ensure the monitoring's up to date, and ensure you know what's the responsibility of the GP and what's the responsibility of the specialist. So controlled drugs. I think, have we already done the poll on this? Is there another one?
Is there another one? I don't think there is another one. No, there isn't another one.
We're all polled out. So I do want to talk a little bit about prescribing controlled drugs. So dosing instructions. As directed is not a legally acceptable dose. One to be taken as directed is okay. One to be taken once daily as directed is better. So you're always better to have a number of tablets and a frequency. quantity in words and figures, I know the computer does this automatically for you, but just in case you're handwriting, the dose doesn't have to be in words and figures though, so you don't have to put like 1 and then 1 in brackets for 4 times a day. It's just the quantity. And also I want to touch on just in case medication. So midazolam is a controlled drug and requires actual directions, not just as directed. The only reason I wanted to talk about that was because I was once working in a supermarket pharmacy late at night and somebody came in with some anticipatory meds on a script, and the dose for midazolam was as directed and I couldn't give it out, and I felt like a really terrible person. So just be mindful that midazolam is a controlled drug and it does need a dose.
Can I just make a comment about the MMT presets? Because we had a significant event last year which turned into quite an interesting quality improvement project from my registrar last year, which should have been rolled out across the whole of the CCG, but was that a prescription for methylphenidates had been done, the shared care had all been checked, but the default from the medicines management drop down said take 1 daily for ADHD, which was put through, and actually it should be take 1 tablet. And oddly, it got dispensed twice by a pharmacist, but the third iteration of the prescription then got sent back, and the family complained that the doctor was incompetent and that it hadn't been done right, and turned into a bit of a hoo-ha. And actually, it looked as though when MMT had set the defaults on the formulary for all System 1 practices in Derbyshire, they had failed to use the words 1 tablets and put take 1. So it was a bit of an SEA for them as well, and I believe it has now been altered, but it's a reason to read what you're doing because the default drop downs aren't always right.
Yes, very important. And I just wanted to talk about 7-day scripts as well, because I've seen this a couple of times. 7-day scripts for controlled drugs. Patients can order a 7-day script 7 days early. So sometimes they can end up with a couple of extra scripts per year. And obviously you don't want that to happen. So just check when it was last prescribed if you're prescribing a 7-day script. It can happen for any drug, but for controlled drugs specifically, more important, I would say. And then I want to talk about the 1-month prescription limit. So for pregabalin and gabapentin, this is often missed, and you often see them prescribed 2 monthly. And then opioid prescribing as well, just keep opioids below 120 milligrams of equivalent morphine. And that's it. So in summary, DOACs, the monitoring depends on the creatinine clearance, the dose depends on the creatinine clearance, weight's really important. NSAIDs do need annual monitoring and monitoring 1 to 2 weeks after initiation and dose changes. QT prolongation, just be mindful if you're prescribing a drug that prolongs the QT interval. To prescribe a shared care drug, you just need to check that the agreement's in place, it's in date and it's been signed, and all the monitoring's up to date. And CDs, just dose them clearly. And that's it.
Brilliant. So thank you very much, Jess. And we've got some resources that you flicked up there as well, so that's useful to know. Thank you very much. That's, I think, really, really helpful. So before I hand over to Amy for her bits, reflecting on that and thinking about what has happened, I'm just wondering if we're thinking about safeguarding our prescribing, actually, if we're thinking about being as near to perfect as we can do with our amiodarone and our lithium and everybody having had their bloods, just wondering how well we think we are doing. So I'm just going to pop up a poll just to have a think about whether we think we are up there or whether we think we are perfect already. Interesting stuff, guys. So I'm going to share those results with you. So that's actually quite interesting, isn't it? So at the beginning, we all were sort of thinking, yeah, we've probably got pretty safe systems. It's all pretty good. And I hope perhaps what we're now recognizing is, okay, we're not actively dangerous. There's probably worse people out there at it. But maybe we're not quite where we need to be. And I hope with Amy's little bit that she doesn't, well, she probably will terrify us, because it was pretty terrifying when I read the article on which Amy's little piece of work is based. And I think we've got lots of work for us to do, and that important recognition of the fact that Jess is an amazing resource that we have between the practices, who is hopefully going to keep us safe and potentially out of the coroner's court. Something I was just going to mention that I forgot to do a slide on, that just may be worth thinking about. I think everybody here is from System 1 practices, and if you are, you may have noticed when you prescribe your DMARDs, it's set up automatically to suck through the last white cell counts, but you can quite easily set up other things. So I've gone through our drugs, and every time I find something I think, oh, I can't remember the monitoring, so I've set the amiodarone to tell you when the last LFTs and the last thyroid function and what have you is. Similarly, I've set all the ACE inhibitors to tell you what and when the last EGFR was, and I've got all the antihypertensive showing when the last blood pressure was, just so that it's a little bit easier if you're busy, that you're not trawling through the notes. It's there immediately on their repeat screen, and it's not hard to do. If you don't know how to do it and you want to know how to do it, I am very happy to tell people, and that's absolutely fine. It is dead easy, or I think Jess knows how to do it, and Jess might be persuaded to show somebody how to do it. I think it does make a big difference. So over to Amy, who's going to share with us another scary prescribing coroner's report, and I think a really valuable bit of quality improvement work that comes out of reading that. So Amy, over to you.
Hi everybody. For anyone that doesn't know me, I'm one of the GPST2s at Wingworth. I'm going to do a talk on adrenaline. So me and Jess have done a little project together looking at the use of EpiPens, Emerald and Jext auto-injectors in our practice population. And we've put a little bit of a project together. So I'm just going to share my screen and get my presentation loaded up. Oh, here it is. So let's go slideshow. So, as mentioned, us three have done a little project together on adrenaline injections. So I don't know if anybody recognises this photograph to start with. This is quite a harrowing story about a poor 18-year-old girl called Shantae who ate something which contained hazelnuts, which she was allergic to in 2018. This was in November of 2018. She unfortunately had a very severe reaction to whatever it was that she ate, and Mum, acted very quickly. Mum got her Emerald injection out, and administered that, and they then called for an ambulance. It's quite a harrowing story. If you can Google this story, it's quite freely available in the news, and there were a lot of kind of worrying factors around the case, which I think have made it quite a significant SCA. And unfortunately, the crux of the story is that this poor girl died in hospital 40 minutes after the ambulance took 40 minutes to arrive, and then she passed away in hospital. So this was kind of the crux of our case, and we thought we would use this as kind of a sort of a learning journey, if you like, so that hopefully we can try and improve people's awareness of anaphylaxis, and wanted to do a bit of a quality improvement in terms of looking at EpiPens, who carries one, how do they use it, do they know how to use it, and would they be prepared if they had to use it on themselves or their child, for example. So what I'm going to talk about is obviously the case, and the types of, I call them EpiPens in general, that's obviously the brand name, but the types of adrenaline injectors available in the UK. And then I'm going to talk about our research, things that we've kind of picked up from the research, and then we'll go on to any questions. If anyone does have any questions throughout the talk, just feel free to just unmute yourself and just chip in, and that's absolutely fine. So Shantae, as I've talked about, was an 18-year-old girl, very allergic to hazelnuts. She instantly had a reaction, and this is a really horrible sort of quote to pick up on, but she said, "My chest hurts, my throat is closing, I'm going to die." She was given one Emerald injection, just one. There was some problems with calling the ambulance, and then obviously, as I say, she then passes away in hospital. So we looked at the report after the case was kind of brought to trial, and there were a lot of kind of worrying areas picked up by the inquest. And there's a lot more, because to be honest, a lot of them were problems to do with the handling of the 111 call, but I'm going to go and try and pick up on the adrenaline and allergy side of things in particular. So the key points is that really mum wasn't aware, and Shantae wasn't aware, that they needed to carry 2 EpiPens, which is what is advised by NICE. So she wasn't carrying 2. They didn't have 2 to hand. She only used 1. There seemed to be some sort of lack of understanding, and the GP looking after Shantae wasn't aware that there was no other kind of input from specially allergist clinic or anything like that. So they weren't aware that they were the only ones kind of, monitoring this. I think similarly, in the same light, they weren't, I think, probably appreciating that they were, responsible for being the sole providers of teaching Shantae and family members how to use the EpiPen, and how to call for help and all of that sort of thing. There was actually a switch in the brand from EpiPen to Emerald, and there was no training given at this point on how to use the new device, which I thought was extremely significant, because they work in different ways, and you would have expected typically, to have brought the patient in surely and given them some training and checked their understanding, and that didn't happen. Because Shantae was of a high BMI, the dose wasn't switched from 300 to 500, and that's talked about in the inquest. And then there seemed to be some sort of confusion about the CCG, and the CCG sort of falsely reassured the GP practice in question, that it's fine to go from brand to brand without reviewing the dose, without sort of reviewing the patient education and things like that. So that was all a little bit worrying. The gold standard when issuing adrenaline auto-injectors is actually to issue a placebo pen as well as the real thing. This obviously didn't happen in Shantae's case, and I'm not quite sure how often this happens in real life, but without kind of giving any spoilers, I'll talk about what we found with our patients later on at the slides. And then, as I mentioned, there's probably the bulk, half of the inquest report is actually problems to do with the actual handling of the call. So it was triaged incorrectly, it was triaged as a category 2 rather than a category 1. The call handler didn't ask to speak to the patient, although they could hear her in the background, apparently gasping for breath, which is quite harrowing. And then there was a problem with the patient's address, where the grandmother's address was actually listed as the patient's home address. So the ambulance ended up going to, grandma's address first, and it was a, big mess, and a classic example of a Swiss cheese model of error. Just as a little refresher, I just thought this was a nice little algorithm for query anaphylaxis. This is, available in most kind of, BNFs, clinical Oxford Handbook medicines and things. Obviously all practices and hospitals and things are geared up for dealing with acute anaphylaxis, and it's something that, we're expected to know in our exams just down pat, because it's very serious, and you can't really be faffing around checking the dosages of the drugs. You need to just know it and things. So these are the EpiPens that you can, sorry, I keep calling them EpiPens, the adrenaline auto-injectors. So most people will have an I
think we've lost your sound, Amy.
well. And I think, if my memory serves me right, the Jext and the EpiPen are the most similar in terms of their mechanism. The Emerald is a little bit different. So we did some research in our practice, and we looked at everybody that carries, I'm just going to call it an EpiPen just for ease, just because I'm so used to calling it an EpiPen, but I'm talking about adrenaline auto-injectors. So we looked at everybody that carries an EpiPen, and we pulled 49 people from our practice, which I think off the top of my head is about 6,000 or 7,000 patients. Myself, Jess and Tara came up with a template which we texted out to our patients who have mobile phone numbers on the system. We were I couldn't get hold of 4 of them. I had 2 solid days ringing people, and 4 of them still didn't answer the phone. So I've gone on a total kind of population size, if you will, of 45 people, including 7 children. So this was our template that we texted out to our people. The first one was kind of checking the understanding about, do you know how to use your EpiPen? And we also provided a video link for each of the different brands, so that people can, you look at that at their own leisure, basically. And obviously, if they've got it on their phone, then they've got it handy, haven't they? And they can always refer back to it in the future. We then asked them, when did you last have to use your EpiPen? Or when I phoned people, I would just say, have you ever used your EpiPen? Is it currently in date? Do you carry 2 at all times? And do you have a nominated friend, family member, work colleague, whoever it is, who knows how to use it, in case it comes to that? So this was a little bit frightening, if I'm honest. So we asked who actually carries an EpiPen, because you would have thought that if somebody has a life-threatening allergy, that's, people would be, carrying these things in and about their person, and it's just not the case. So 4 people that I spoke to were actually quite blasé. All of these 4 people were quite blasé, and said, oh, there was no shame there. I never carry it. I don't know where it is. All of this, and my heart was pounding, and I was thinking, oh my goodness, this is a problem. So at least it was only 4 and not more than 4. Most people did carry 2 pens, so just over half the population that we interviewed effectively did carry 2 pens, which was very reassuring, and 26.6% just carried 1 EpiPen. However, interestingly, this was mostly because most people that I spoke to that said, oh, I just carry 1, went on to say, oh, well, doctor, the other one's in my car, the other one's in my other handbag, oh, my husband has the other one, sort of thing. So they knew where it was, and it wasn't negligence, but it was their way of thinking that it was being safe, because if they have one on them, they know where the other one, sort of thing, is. So I actually found that a little bit reassuring, actually.
Amy, can I ask?
Yeah.
I'm not sure. I've never looked at a adrenaline auto-injector box itself. Does it have any safety warning on there to carry 2 at all times?
I don't actually know. Bear with me 1 second, and I'll get mine, and we'll have a look.
I've seen them in community pharmacy, and I don't think they do.
I don't think they do either. But I know when you... Right, so...
Like a smoking pack, sorry, a cigarette box has smoking kills, same way anaphylaxis kills, but so carry 2 auto-injectors at all times.
So interestingly, on the actual EpiPen itself, it gives you, I don't know if you can see that, but it does actually give you instructions on how to use it.
Can't see your video, sorry, Amy.
Oh, sorry. You can see...
If you unshare your slides, Amy, then you could show us.
Oh, gosh, I'm such a technophobe. Oh, here. If I can see... This is the EpiPen. So it actually give you this is the real one, so I'm not going to throw it around too much. and then on the back it just gives you the ingredients really.
Yeah,
So
yeah.
it doesn't tell you to carry 2, but if you go on the EpiPen website, and because I was doing some research and having a look on the EpiPen website, that does say very clearly to make sure that you carry 2, because it goes on to say use your other one, you know, 5 to 15 minutes after you've used the first one if you need to. So, or maybe I'll have to get in the box, you know, and have a look and see if it says it. I don't think it does say it on the box. I think if I remember, it's just a yellow box. But I'd be so it doesn't say it on the actual thing, but it does say it on the EpiPen website. So yeah, I hope that was helpful.
Yeah, thank you.
That's okay. So just going back to our template. So so have people used their pens before? So 22% had actually used their pens before, and then one poor bloke said, oh, we'd used it more than 20 times, which I thought was quite incredible. I've had an EpiPen since 2007, and touch wood, I've never had to use it. So I don't know what he was doing, but we had a long chat about making sure that he has it on him at all times and things. Most people hadn't used their EpiPens before, which was, you know, quite reassuring. And interestingly, a couple of people, and these were the older people actually, I wanted to tell you this, Jess, when I was going through the list, it was about 2 or 3 older people, sort of over 65, said, oh, I've had my EpiPens, you know, for years, I've never used them, do I still need them? At which point I said, yes, please do carry them, just, you know, on the off chance that you come into contact with whatever it is that you might have once been allergic to. With the pens in date, now I'm going to be honest, I am guilty of having an expired EpiPen in the past, and it's my poor dad who has to remind me about that. So, but we're among friends, so I don't mind admitting that. But a lot of people, 36% actually said that, you know, their pens were either out of date or they didn't know if their pens were out of date. Some people seem to not really know where they were, not really have them to hand, and, you know, there was a little bit of confusion about, you know, were they in date or not. I know Jess has issued some prescriptions, and then I issued 6 prescriptions on Friday to people who had either used their pens and didn't have any left, or just simply didn't have an up-to-date prescription. I thought 50%, I thought that was reasonable actually, could confidently say that their pens were in date. So these are people that, you know, didn't even need to go and check them. They just, I mean, hopefully they were being truthful, but they knew that their pens were in date. So I thought that was, you know, that was quite reassuring. So what were the good points highlighted by the research? So most people, 44 out of 45 people, knew exactly how to use their EpiPen, or they'd seen the video, or they even mentioned that they remember being trained in person. One poor lady said, oh, I've got no idea how to use it. I'm really hoping that my husband's going to know what to do when the time comes, which, you know, again, we had a long conversation about how to use it. Majority of people carried at least one, and quite a lot of people carried 2. So I thought that's quite good actually. And then we've talked about that. So the people that carried 1 pen, I wasn't sort of worried about these people, because I think it was just a bit of an education, if you like, about, no, actually you need to carry your EpiPens with you. It's not to have in the car, because, you know, if you go to a restaurant and you need it, you know, no one's going to know what car you're in, sort of thing. So yeah. A couple of people said that they had a placebo pen at home, which I thought was really nice. I've got a placebo pen, and you can register for a free pen, placebo one, on the Jext and EpiPen website, and that's completely free of charge. So I would be encouraging our patients, probably when I ring them all again, to check on how they're doing with their EpiPens, just mention that they can register for a free placebo pen. Everybody had a family member or a friend who knew how to use it, which is really good. And most people, I've just duplicated that, so that's fine. So things to improve. So that's probably a really good photo actually of how to use the EpiPen. This is the trainer version. So the areas of concern was obviously the 4 people who, you know, didn't carry an EpiPen at all. So I think, obviously, I've had a conversation with these people and said, you know, that's, you need to really not take responsibility, but, you know, if you were to come into contact with something you're allergic to and have a severe reaction, the best thing that you can do for yourself is to have, you know, these auto injectors on your person, in your handbag or your coat or whatever. So we've had some long chats. I think it's education about the importance of carrying both pens. So it's not one in each handbag, as one lady said to me, it's 2 in the same handbag. I think there's some encouragement about watching the training videos and just refamiliarizing ourselves with how it works. So do you press the button, do you jab it, you know, the different ones work in different ways. And then obviously keeping an eye on when they expire. I'm not sure if anyone remembers, and I think it was 2018 when there was a shortage of EpiPens. I was told, and I remember I actually did an audit at my other practice at the time on EpiPens, and had to ring people and tell them to keep hold of their old ones, even if they've expired, because I think they're still good for a few months after they expire. So don't kind of, you know, trade them in at the pharmacy just yet, just hang on to them for a little while. So obviously, you know, keep an eye on when they expire, but they are actually good for a few months after their sell-by date. So I'm just going to touch on this quickly, things that we can do to hopefully improve sort of compliance and understanding with anaphylaxis and EpiPens. So I think this should be quite a standard thing and quite an easy thing that we can achieve, which is an annual review of EpiPens. Even if it's just a phone call, it can very easily be done as telephone triage. You know, if people aren't able to come to the surgery, do you know what you're doing with your EpiPen? You know, have you ever used it? Have you seen the video? You know, and this sort of thing. And issuing of new pens as and when. A face-to-face annual review of allergy status, particularly if the GP is the sole provider for allergy care, which is going to be the case in most cases, with a refresher on anaphylaxis and obviously the video. And I think it would be nice, obviously COVID permitting, if we could bring a family friend or a family member, or friend to the appointment, and they can even, you know, you can all watch the video together, which, you know, might seem time consuming, but I think it would, if it could prevent a case like Shante that I talked about at the beginning, then surely that's a good thing. Issue of 2 up-to-date pens each yearly review. A lot of people that I spoke to said they've got 1 that's in date and 1 out of date. So I'm still kind of tackling through that at the moment to try and get people to have 2 up-to-date pens at home. An up-to-date weight for children. So I've asked some of the parents of children with EpiPens to text me their weight for their child, just to make sure that we're not missing them going over this this kind of mark, because then they'll be obviously requiring a bigger dose of EpiPen, and we don't want them to have some sort of accident in the school canteen with whatever it is that they're allergic to, and then, you know, heaven forbid, they've only got a 150 mic pen and not a 300. Yearly AccuRx template, because AccuRx is so good and handy, and loads of people were really responding to the text, which is really, you know, encouraging. This is, you know, it's so easy and so quick to do. So we can even do that, you know, if people aren't able to come to the surgery, just to kind of check in and, you know, make sure that they're happy with their EpiPens, and they're okay with being up to date and all of that stuff. And then, as I talked about as well, registering, there's an expiry service. I'm learning so much. I didn't even know that there was an expiry service, so I'm going to get my EpiPen on there. An encouragement to register for a free placebo pen as well, just so that you can use that to train your family and friends. And this is just a little photo of when I was an F2 on spinal surgery. Someone saved me a nut-free mince pie, so I thought that was cute. So that's my research. I just want to say a big thank you to Tara and Jess for helping get it all together. It was a really successful kind of task, if you like. It was really encouraging to see people responding to the AccuRx template in such a positive way, and people were very grateful actually for the call when we spoke to people over the phone. I know Jess had some interactions with people as well. They were really touched that we rang just to see, you know, check in about their EpiPen status. So I think it's definitely something that we can make a big change with, and it would be nice to kind of put that in action and hopefully see it going forward in the future. So thank you for listening, everybody. I hope that was okay.
Brilliant bit of work. Thank you very much, Amy. I think it's a really, really useful bit of work. And you know, we're happy. I think Amy and Jess very happy to share the methodology across if any other practices want to pick that up. And I'm desperately trying to persuade Amy that she needs to get that written up and published somewhere, because I think it is well worth doing that with. So we're going to go on to one final little bit of prescribing, I hope. Bear with me just a moment, because I didn't mean to do that. So get there eventually. So I'm just going to share with you at the end another little bit of there's so much scary prescribing, isn't there? I think we can all get absolutely petrified and never ever want to prescribe anything ever again. But if anybody reads the BJGP, I'm sorry, you've probably seen this already. I frequently file mine in the bin. Unfortunately, it comes in plastic, so you have to take the plastic off before it goes in the recycling. And then as I was peeling the plastic off, I actually opened it this month and thought this was potentially quite useful. So this is a summary of lessons from the Cumberledge report, First Do No Harm, which is published in July 2020. So this is a little bit of a brief Journal Club run through an article in the BJGP, which was based on Baroness Cumberledge's report. So this really focused on issues relating to women's health. And it mostly focused, if we're thinking about prescribing, on valproate. There was also quite a lot about pelvic mesh. I'm not going to talk about pelvic mesh because we know pelvic mesh has been a huge downside for many, many women, and there are lots and lots of lawsuits, but it's not really anything as GPs that we encouraged or had very much to do with, other than recognising that we will have patients who've been affected by it. But I thought this was quite damning of us as a system. We found the healthcare system is disjointed, siloed, unresponsive and defensive. It does not adequately recognise that patients are its raison d'etre. It's failed to listen to their concerns, and when belatedly it has decided to act, has moved glacially. So nothing like a little bit of GP bashing to get me my blood up and think, hang on a minute, Baroness Cumberledge, is what you're saying fair? And sadly, I have to admit, I think she's probably right. So a little bit about valproate. So valproate obviously was licensed in 1972. We've all heard of valproate. And by 1984, so 12 years later, there was some clear evidence of teratogenicity. And remember, this is around, this is not long after the thalidomide scandal. This is not long after one of the biggest cases of a teratogen given to pregnant women. And oh my goodness, nothing like this must ever happen again. Yet there were over 20,000 exposed pregnancies, and in 40% of those pregnancies resulted in severe neurological defects directly attributable to valproate. But it wasn't until 2017 that the MHRA actually decided to produce a safety statement. And I hope most of you now know that since 2017, there's been a requirement for prescribers to document a pregnancy prevention plan, and a decision now to say that valproate should never be started in women of reproductive age. So I suppose a little question to have a think about and take away for your practices, actually, have you audited that? I think in 2017, there was so much from the MHRA that I think most of us went away and did some work on it. But actually, that work is only as good as the time was when you did it, unless you are utterly, utterly sure that any patients started on valproate by epilepsy specialists, pain specialists, psychiatrists, moving into your practice area from elsewhere where they weren't safe prescribers, moving from abroad where valproate still seems to be given out with gay abandon. Actually, can you guarantee that your practice is safe? So that was my first thought. But I suppose it's also thinking, so perhaps if you want to stick on the chat for me for a minute, what other teratogenic drugs are really commonly prescribed in your practice? Okay, so we've got a few thoughts coming through there. So the main ones which you talked about in that report are ACE inhibitors. And of course, if you've got somebody who is hypertensive and under 50, an ACE inhibitor is going to be your drug of choice, isn't it? I know most of our hypertensive under 50s are probably 47 and male. But actually, I would love to think I can put my hands on my heart and say I have no patients under the age of 50 who are female and have a uterus who are on an ACE inhibitor and not on a long-acting reversible contraception. I'd love to say I can say that, but actually this has made me have a little bit of doubt. So I certainly got some ideas for audit. Going on from there, carbamazepine. Again, we don't prescribe a huge amount of carbamazepine, and it's often secondary care that have prescribed it. But particularly with valproate being less and less used, we are more likely to end up with valproate. Lithium, again, though, if people came to my perinatal talk, lithium is a really interesting drug because we still don't really know whether lithium causes Ebstein's anomaly or whether it is something to do with the epigenetics of people who are susceptible to bipolar. But you'd be a brave person to give somebody lithium and say, yeah, crack on, get pregnant, don't worry about it. So, you know, I think that's worth thinking about. Carbimazole, people with Graves' disease, warfarin. And again, I think we like to think, oh, well, we mostly are prescribing DOACs. DOACs aren't great in pregnancy. But, you know, warfarin is a very commonly prescribed known teratogen. And again, I think we go, oh, warfarin, oh, that's for like people in their 80s with atrial fibrillation, and don't remember, you know, the 36-year-old lady with factor V Leiden who had a DVT because somebody put her on the pill because they didn't know she had a clotting malformation. And then they put her on warfarin, and she can't have the pill anymore. And nobody really thought about what was going to happen in terms of pregnancy risk and being on warfarin. Statins, again, and particularly thinking about young people, you know, there's a few families around who've got familial hypercholesterolemia, really important that they have planned pregnancies. And obviously Roaccutane, which I think dermatology have got really good at the whole belt and braces 2 methods of contraception with them. But just, you know, as a bit of a rhetorical question, what systems have you got in place to consider teratogenicity risk? And it's something I feel quite strongly about, actually thinking about recognizing if you've got people who are on teratogenic drugs or people who've got significant underlying health conditions. Because actually, if you've got a young person on an ACE inhibitor and or warfarin, perhaps who's got a cardiomyopathy, really, not only are you worrying about the drugs being dangerous to a potential baby, but also that pregnancy being really dangerous to them. So it's a sort of a double whammy of thinking people who are on these drugs may well be people who really need to be having really well planned pregnancies. So actually really thinking about making sure that contraception is the default position for them, rather than an optional add-on. So I just thought this might be quite a useful audit idea to take away. You know, female patients between 13 and 55 who have a uterus who are prescribed any of those drugs should be on a LARC method of contraception or have documented sterilization recorded in their records. And again, you know, doing the searches, looking at that, you know, that is something that, you know, we could consider whether it's something, you know, as a PCN project to run across. And I'm just nominating Jess to help with this, because I know this is really up Jess's street, just thinking about, you know, keeping our patients safe. But it also actually probably reduces our workload too, because actually if you're not being faced with lawsuits about inappropriate prescribing, or you're not stuck with actually having a difficult conversation with somebody who rings up and says, oh, I'm pregnant, I'm on warfarin, should I be worried? You know, that is going to destroy your morning surgery, isn't it? And actually, if that's preventable, that's really got to be a good thing. So thank you folks very much for listening. We would all really value some feedback from tonight, if at all possible. And so I'm just going to put, there's a SurveyMonkey link, which I'm going to stick into the chat. Though there is also, if I can find it, if people prefer, the good old QR code. If you want to pick up your phone, and that QR code should take you through to that SurveyMonkey link, I hope very much. So I shall give you a moment to snap that or click on the link. So thank you very, very much for your time and attention tonight, folks. It's all really, really much appreciated. I